Today we're just going to talk about pulmonary pathophys, and then we're also going to go over fetal circulation. So we're starting with, not this slide, but let's see. So starting with restrictive versus obstructive pulmonary disease. So what's important to remember is the difference between restrictive and obstructive pulmonary disease is that with restrictive, it's you lose compliance, and so that means it's difficult for the air to actually come in, so it's difficult to inhale, but you're pretty okay with exhaling. And so examples of that are pulmonary fibrosis, acute respiratory distress syndrome, pneumonia, inhalation disorders. And then we also have, on the other side of things, obstructive pulmonary disease. So those, it's difficult to get air out. So you can breathe in, inhale just fine, but then it's difficult to exhale. So the FEV1, which is roughly like how much you could breathe out in that first second, that's decreased. And then the ratio of how much you could breathe out over, I guess, the total amount of air that you could possibly hold in, that ratio decreases. And so you can have asthma, emphysema, or chronic bronchitis for this example. With obstructive pulmonary disease, so again, it's very difficult to expire, so breathing out, and you can have dyspnea and wheezing, so just difficulty breathing, and then these three cases. So with COPD, which is the chronic obstructive pulmonary disorder, that could be a problem when, so you have a mucus plug that when you breathe in, it's okay because the airflow is coming in and you're not contracting, like you're opening up the airway, so air can come in just fine. But when you're trying to breathe out and you're trying to kind of collapse the airway to push the air out, then that's where you see the problem, because then this part kind of narrows and then the air really can't circulate anywhere. So with asthma, it's a hypersensitivity response to an irritant. You can have increased vasodilation, vascular permeability, and vascular congestion. And so basically, following along all of this, it basically is just telling you more about airway obstruction, and it's due to that allergic response or irritant response that triggers it all. But with COPD, which can be split into chronic bronchitis versus the emphysema, so with chronic bronchitis, you've got a problem with mucus hypersecretion. So in asthma, you get a lot of mucus as a result of the inflammatory response, but here you get just mucus secretion because of kind of like a different response, like I guess a different kind of immune response. And then with pure emphysema, you have these tiny alveoli that are typically supposed to be separated, like they're supposed to be very small, but then instead, if you lost the wall between all of them, you kind of lose that recoil. So when you try to contract that kind of, instead of a grape shape that can contract pretty easily, and you're trying to contract like a melon shape, then you're losing out on the elastic recoil. So that's why it's an obstructive disorder. So So looking at this slide, COPD, so A is normal, but COPD encompasses B and C, which is the emphysema and the chronic bronchitis. So with emphysema, you lose the elastic recoil. You can inflate okay, but you can't exhale very easily. And then in chronic bronchitis, you have mucus hypersecretion. It's inflammation of the bronchioles. And then because of that increased mucus, then it's difficult to breathe the air out. And then you also have lots of mucus accumulating in the case of asthma, and that's just some sort of irritant or allergen exposure that triggers the immune response. So in the case of restrictive lung diseases, I would just make sure you can kind of like get the difference between like FEV1 and the FVC. So you know that the ratio of FEV1 over FVC is normal, and there's no change in expiratory flow rate, but there's a reduction in, I guess, how much you could actually get in inhaling. So the forced vital capacity is the biggest difference. So this slide is showing the pathogenesis of chronic restrictive lung disease. So in this case, you have lung injury, and then your macrophages get activated, and you end up with some form of hypertrophy and hyperplasia of your like lung cells. So then you get scar tissue getting laid down, and then you have more collagen, and the collagen can't really contract as easily. You're losing out on the elasticity of like the normal alveolar walls, and so it's not really stretching very easily. So again, losing that inhalation ability. So this chart is pretty important, and I would make sure to study this one just so you know the difference. Like, okay, FEV1 over FEC is decreased with obstructive, normal for restrictive, and then like which one is normal, which one is decreased for each of them. And that could be like a one-liner on your cheat sheet as well. This slide is talking about, so it's a flow volume curve, and it's basically talking about like with bigger lungs and like barrel-shaped chests, you have a lower flow rate, and there's lots of air left in the lungs. Like it's kind of difficult to deflate them all, and then it's just, yeah, you don't really need to look too much into it. But, yeah. With pulmonary vascular disease, you can have a pulmonary embolism. Sorry, I'm going to back up. Okay, with pulmonary vascular disease, you can have a pulmonary embolism. And to remember, embolisms are when you have like some sort of clot that gets, like pushed onto somewhere else, and it kind of ambles along the bloodstream somewhere. And so it can arise from the deep veins in your thigh, for example. And because of the blood not moving well, and like this clot, the blood won't circulate very well. So with pulmonary embolisms, you can have venous stasis. Yeah.
On the Virchow trial,
Trying.
we have to know like that in detail. Like, what exactly?
I think like on my cheat sheet, I think I might have put this picture. Yeah. So I didn't put this specific picture. I put the COPD picture. But I think these are more simple cases, and it's just kind of saying like if you have a pulmonary embolism, that all of these factors kind of accompany it. So like you can have the hypercoagulability, or some sort of vessel injury could lead to the embolism. Basically, like think what could form a blood clot, and from there, if you had a blood clot, what would happen? So you would have some sort of blockage to your pulmonary circulation. If that happens, then pulmonary edema could arise, and then basically all of these bad things could happen. So difficulty breathing, slower breathing rates, chest pain, etc. So this, I guess with the Virchow's triad, it's just saying like what are possible factors that could lead to it, and it's not necessarily like, I don't think he'll say like what is venous stasis or anything, but like if you saw it in the form of like a clinical kind of question, then you could kind of be able to think, okay, well, if they had some sort of vessel injury, could it somehow lead to a clot formation? Could that clot somehow, feed back on the lung or lead to pulmonary edema? And if, your lungs have edema, then you get all these other shock-like problems. So pulmonary vascular disease, you can have pulmonary hypertension, and so hypertension is just, you know, the higher pressure that it's used to. And then you can have different classifications of how you get that hypertension. So I think this is the slide, this is the figure that I included in my cheat sheet. I think it's just because there are a lot of words that I wasn't sure about. So COPD, interstitial fibrosis, or obesity hypoventilation syndrome. So basically things that make it difficult to breathe can lead to problems of low oxygen or some form of acidosis. From that, because we don't have enough blood or enough oxygen, we're trying to get more oxygen into the system. But we happen to increase blood pressure to the lungs from the increased from that constriction on the pulmonary artery. You can have some sort of progression of pulmonary hypertension, but it could be reversed with some form of treatment. If not, you have fibrosis, so the collagen laying down, scar tissue, that kind of thing. And then if you have that scar tissue building up, then it's more and more pressure because you can't contract as easily. Then you have cor pulmonale, which is when you have the hypertrophy and dilation of the right ventricle, because the right ventricle has to make sure you get the blood into the lungs, and if the lungs aren't really permitting that, then they have to work harder. And if the right ventricles have to work harder, they end up hypertrophying, getting bigger, and eventually starting to fail because they overwork and they can't actually get the blood through. So that relates a lot to the fetal circulation. The same thought processes all involved. With lung cancers, it's important to note, well, I guess it's obvious that heavy smokers have a greater chance of lung cancer than non-smokers, but also remember that there's environmental or occupational risk factors, and you can have these two types of cancer called small cell carcinoma or non-small cell. So with the cancers, be sure to note the different kinds, like these 4 kinds. So the first kind, squamous cell carcinoma, it's slow, it's got some form of cancer near the hilus. That's like this part of the track, I guess. You can also cough up blood because the cancer is chewing through the bronchi and it's obstructive with a cough. Small cell or oat cell carcinoma, it's very rapid and it just forms like very, very big, and it's most correlated with smoking, very high mortality. And you can also have ectopic hormone production. So this cancer might make some sort of hormone that gets picked up by like the endocrine system, that kind of thing. Adenocarcinoma, it's somewhere kind of on the outer periphery of the lung, and it's less correlated with smoking. It's just kind of moderate in how quickly it spreads. And then large cell carcinoma, again, it's very, very big, very, very rapid. It's important to note the 4 types, or I guess all of these different types of cancer staging. So my advice is on your cheat sheet, like for you to memorize going into the exam, know the difference between T1, 2, 3, 4. I guess be able to classify it. Like if you saw that it said like they had some form of spreading to this size, or spreading to the lymph nodes, like to the periphery, etc., like be able to identify that as N1, 2, 3, 4, T1, 2, 3, 4, and then on your actual cheat sheet, you'd be able to put all of these numbers, like type 1A is T10, because he will ask maybe 1 or 2 questions on this. And I don't think he asks you percentages, but it might help like to know like this is more common than that or something like that.
So just memorize like the previous ones?
Yeah, so like memorize what actually T1, 2, 3, 4 actually mean, but on your cheat sheet, you can actually just write down like type 1 is T10, N0, M0. And then if you have any form of metastasis, that's always stage 4 cancer. Yeah. And then you can have limited cancer staging, and that's like a less than 20% chance of 5 years survival, or extensive cancer, which is very, very low survival chance. Other forms of lung cancers, bronchial, carcinoid tumors, adenocystic, mucoepidermoid, and mesotheliomas. He doesn't really talk about them too much, so I'm not going to cover them too much either. Also, remember, you can have pneumonia, and pneumonia could be community or hospital acquired, and there are 2 different kinds, remember? So hospital acquired, that's another way of saying nosocomial infection, and that's like a patient could get it from just being in the hospital because it's like circulating around. Community is more like you're out and about, and like at a park or something, and like people start infecting each other out there. You could have pneumococcal pneumonia or a viral form of pneumonia. So just different bacterial or viral infections could cause pneumonia. It's just a different strain or different type. So with pneumococcal pneumonia, so that's this bacteria causes the alveolar macrophages to adhere to, I guess, different cell wall components, and then you get to this point where you get some sort of infection and resolution. It's kind of like the same that they all sort of are. Tuberculosis is a pretty big one to know as well. Remember, with tuberculosis, it could also be correlated with caseous necrosis, back from like one of the first PowerPoints. And you can test for tuberculosis with a PPD test, which looks at a certain protein that's made from the bacteria. It's caused by Mycobacterium tuberculosis. It's an acid-fast bacillus, and it's airborne transmission, so if you cough on someone, they could get it from like the respiratory droplets. It's important to note with tuberculosis that it can be latent, even if you like supposedly got rid of it, and then it can always come back. So it's very difficult to make sure that it stays gone forever. So I guess I would look at this and make sure I understand, like, from a primary infection, it could heal and then all the organisms die, or the organism lie dormant, somehow get reactivated, reinfect the cell, and you can have secondary tuberculosis, and it can progress and cause some form of death or much greater problem. Acute bronchitis is another form of respiratory infection. It could follow a viral illness, and then it's similar to pneumonia, but it doesn't have the like bacteria that's infecting all of those different pathways and causing blockages and stuff like that. Cystic fibrosis is an autosomal recessive disorder, and it causes a defect in chloride transporters. So your mucus ends up really, really dry and hard, and you can't really cough up very easily. And so mucus typically is there to trap the bacteria, and if you can't cough it up and like get it out of your system, then like all the bacteria just kind of like stays there, keeps infecting you. So you want to make sure with these patients that they can be able to cough everything up or clear their system. You can have different inhalation disorders, like exposure to toxic gases, pneumoconiosis, and so it's important to know the difference between like silicosis, coal worker pneumoconiosis, and asbestos. So there are 3 different kinds. So silicosis from silica dust, coal worker pneumoconiosis from working in the mines, and then asbestos from like asbestos. Or you could have this hypersensitivity pneumonitis, which looks the same, but you could have it caused from bird fancier's lung, which is exposure to bird feathers and their droppings, versus farmer's lungs, which is from mold. So all of these types of inhalation disorders, he might ask you to differentiate like one of them, like which might be pretty straightforward. Acute respiratory distress syndrome. So with this one, it's just there's different types, but basically surfactant gets inactivated at atelectasis, and you can have rapid shallow breathing, respiratory alkalosis, dyspnea, decreased lung compliance, and unresponsive hypoxemia. So you want to make sure that you understand it is a form of respiratory failure. It goes under the restrictive lung disorders category. And there's type 1 ARDS, so you have low oxygen and low CO2 content. And then type 2 is like low oxygen but a high CO2 content. And it's just, the difference is like in type 1, it's kind of like you hyperventilated to try to get rid of CO2. And then type 2 is like if you weren't breathing for a while, then you kind of have that buildup of the CO2. I think I also included this on my cheat sheet, but not sure how necessary it was, but it's just some form of insult causes you to have this inflammatory response, and you could have damage to your lung system, and you can have pulmonary hypertension, fibrosis, edema, and decreased lung compliance. Postoperative respiratory failure, these four fit under that umbrella. And then with age, you lose elastic recoil, the chest wall stiffens, so you can't really breathe out the same as easily. So the lungs are the same size, you have the total same total volume, same respiratory rate, but a greater residual volume because you can't breathe out as much, as easily. So aging lung, this graph, if you like looked at it carefully, is kind of just showing you like how much you can actually breathe versus not breathe. And so it's just outlined again on the previous slide. So these different components happen with aging lungs. And that should be it for now. So now we'll transition over to the fetal lung components. Okay. Any questions with the pulmonary stuff? Cool. Okay, so with fetal circulation, know the parts that are special to the fetal that are not in the normal, like, adult lungs. So that's umbilical arteries, umbilical vein, ductus venosus, foramen ovale, ductus arteriosus. So the most important ones that you'll see come up more often are the foramen ovale, which is between the two atria, left and right atria, and that gets shut. So like normally blood can just kind of go between the two, and then it closes once you get older to divide the two chambers. And then the ductus arteriosus, so that's up top between the pulmonary arteries and the aorta. And that's because, remember, with fetal circulation, they don't use their lungs. They get their oxygen from the mother, from the placenta, all that stuff. So then they don't really need to send that much blood to their lungs to get oxygen because the lungs aren't breathing or anything. So you just send a tiny bit of oxygen to the lungs to make sure the lungs are functioning. But other than that, oxygen is down here from the placenta. So this outlines, I guess, the pathway that it all goes through. So I think it is fair game to say you might be asked to order the pathway flow of how everything goes. So in the mother's circulation, you've got the umbilical artery going from mom to fetus through the placenta, umbilical vein, which is now oxygenated because you got oxygen from the placenta. The liver, you go through the ductus venosus, then the inferior vena cava, up through the right atrium, and then through the foramen ovale you can get to the left atrium, and then through the left atrium to the left ventricle, to the aorta through the ductus arteriosus. Also, the right atrium still can go to the pulmonary artery and ductus arteriosus to the rest of the body as well. Let's see. So also remember, vascular resistance in the lungs is high, and you have so you because you don't need to send that much blood there. But then after you start breathing, you want to decrease resistance, because now you actually do want to send the blood to the lungs. So it's low vascular resistance, high peripheral vascular resistance for kids, and then the ductus venosus is then called the ductus ligamentus, and then the ductus arteriosus is supposed to close after about a week, and the foramen ovale is like that little, it'll kind of flap and close itself, and the pressure from the two atria will make sure it stays closed normally. Okay, sure. Yeah, no problem. Yeah, so let's see.
Could you also send us these
Yeah.
slides?
Definitely. I guess going through this slide just talks about all the different heart defects. So a good test for yourself is like if you can look at the name and kind of picture what it's saying. Also, the name itself is always helpful. Like, you know, if you could say like, what is a coarctation? What does stenosis mean? What does atresia mean? Then it helps you break apart like what the actual function of the defect is. And so the big theme is categorizing cyanotic versus acyanotic blood flow. And so cyanotic does not have the oxygen. Acyanotic is correctly oxygenated. So again, we've got the shunting of the blood, left to right, right to left. And then tetralogy of flow is what I have written down here. But typically with atrial-septal or ventricular septal defect, because the left side has greater pressure than the right side, then you'll have a left to right shunt. But in the case of tetralogy of flow, because you have a built-up right ventricle, then you have blood shunting from right to left. And we'll go into detail soon. So with the atrial septal defect, you've got, let's see, you've got, because the septum is no longer separating the two atria, then the higher pressure left atria can shunt the blood from left to right. And that's what how the defect works. Same with the ventricular septal defect. So depending on the size of it, you can have small blood coming through or a lot of blood coming through. Atrioventricular canal defect, so that's when the two valves are fusing and they won't separate properly. So with the pulmonary artery and the pulmonary aorta, they're basically the same pressure because the two valves aren't correctly separating. And then you start to have a mixing of blood, and it's slightly deoxygenated blood in the aorta. But overall, it's acyanotic because we do have, I guess, sufficient blood flow to the whole of the body. But we do have increased pulmonary blood flow because we've got the mixing of like the left and right side blood that typically isn't mixed. Patent ductus arteriosus. So you could have problems with this connection right here. So after the blood goes through the aorta, typically it'll just keep going down. But if you have this connection where the aorta branches into the pulmonary artery side, then you have increased blood flow and this continuous murmur that you'll see on clinical cases. And then you eventually have a little bit less blood going to the rest of the body because you have too much going through the lungs, and you have this increased pulmonary hypertension. So again, left to right shunts, you see they're acyanotic because you're getting enough oxygen to the system, and then you have increased pulmonary blood flow. So atrial septal defect, ventricular septal defect, patent ductus arteriosus all have left to right shunts. Next we have the coarctation of the aorta, and so that's usually near the ductus arteriosus. So what you'll see is a narrowing. So if it's a preductal, or if it's postductal, meaning it's after the subclavian artery, then blood flow normally can go to the upper half of the body, which is why you'll see a high blood pressure in the upper part of the body. But then you've got this narrowing, so less blood is actually going to the rest of the body, so it's a low blood pressure in that regard. So you'll see a weak pedal pulse, and because the kidneys, which sense blood pressure, are in the lower half, you'll also have renin production because they think that you're not getting enough blood flow to that side of the body. Preductal, meaning the coarctation is actually above where the branching is, so you have like less blood flow to, I guess, everywhere in the heart, and then you also have blood going through to the pulmonary side, so you have increased return from the lungs and decreased ventricular outflow caused by this coarctation, and eventually the left heart can fail because this has to push to the rest of the body, but it can't because it has to work against this narrowing. And then because more blood keeps coming back from the lungs, because like whatever came out here goes through to the lungs, then it's like even more volume is circulating here. So it's like you have to push harder to get more blood out, but you keep filling with more blood, so then it eventually will fail. Yeah, but it is acyanotic due to obstruction to the blood flow from the ventricles. This is a picture of a balloon angioplasty. So what it does is it's literally like a balloon that you stick in to make the branch, the valve or area like bigger, and it tries to loosen everything up. Oops, sorry. Yikes. Okay. Aortic stenosis, so just like what it sounds like. So stenosis meaning like more difficult to, it's like narrowed and it's more difficult to contract and get things through that area. So for aortic stenosis, the aortic valve is narrowing, and then when it narrows, then the left ventricle has to work harder because it's like a smaller opening. So if it's a smaller opening, you have to work harder to push the normal amount of blood through, and then you don't have mixing of blood in this case because it's still two separate systems. So the left ventricle hypertrophies. If the left ventricle hypertrophies, then you kind of have a backup on like the left atria, and then you can have some forms of pulmonary congestion because it kind of, again, it's like that, the whole concept of like, if one problem occurs, then like the next part above fails and then keep going back. So then pulmonary congestion is like a logical like thing. If this part had a problem, this part has a problem, then the lungs have a problem. Pulmonic stenosis, so the valve to the pulmonary system is getting narrowed, so then the right ventricle has to work harder. If the right ventricle has to work harder, the right atria also gets increased pressure. And then if the right atria pressure gets big enough, then it could reopen the foramen ovale, and then blood could get mixing. So this time it could be a right to left shunt, and you could get cyanosis if enough venous blood shunted from right to left. So that's only in like the more extreme cases, but it is possible if like blood started going from right to left, because it's deoxygenated blood going to the left side, which feeds the rest of the body. Next we have tetralogy of flow. So this is the most common cause of those cyanotic blue babies. And so what happens is so tetralogy meaning four things happen. So basically the aorta moves over and pushes down on the pulmonary outflow tract, and then you have pulmonic stenosis, because the aorta is literally pushing down on the pulmonary valve. When you're pushing down on the pulmonary, then the ventricle, the right ventricle, has to work harder to get the same amount of blood through to the side. And then if the right ventricle works hard enough, it could get more pressure than the left side. And if it gets more pressure than the left side, blood could be shunted from right to left. And then if it's a right to left, it's deoxygenated going into the oxygenated system, so then you have the cyanosis. So severity depends on how much stenosis you get. So like how over top is that aorta pushing down on that area. And because the aorta is over top the septum, that's how you get that ventricular septal defect that like causes this like opening, which causes like the mixing. Tricuspid atresia. So atresia in this case means there's no hole or opening. Tricuspid is saying like the tricuspid isn't opening. So tricuspid valve is on the right side. So if you can't get blood from the right to the right atria to ventricle, then blood has to find another way through. And so to do that, blood has to get through from the right atria to the left atria through the foramen ovale. The right ventricle isn't getting blood anymore because nothing is going to it. So then right goes to left, and then you get almost like 50% mixing of oxygenated, deoxygenated blood, because the right atria goes directly into the left atria eventually will go to feed the rest of the blood system, and then your right ventricle is just kind of out of the picture because nothing is flowing to it. This one is called the transposition of great vessels. And so what happens is, it's kind of like the left and your right sides kind of reverse their normal circulation. So it's like the right side feeds the aorta, which feeds the rest of the body, but the right side has unoxygenated blood to begin with. So then you're circulating unoxygenated blood. But then you've got this unoxygenated blood from the left side because you fed the body, and then it goes to the lungs, so you like pick up oxygen, but then it's not really circulating there either. So in general, like you have all of this mixed blood, and you have major problems with deoxygenated all around, because you're not going normally like right side to the lung, left side to the body, and instead you're keeping it separate. And so in utero it's okay, but then after birth the kids have to get some sort of in utero surgery to fix that before they're actually born. Total anomalous pulmonary venous connection. So it's a fancy way of saying the pulmonary veins enter the right atrium. So instead of feeding the left atrium, oxygenated blood is coming back to feed the right side. And if it keeps feeding the right side over and over again, then you come to this point where you have a lot of pressure in the right side, and so you can shunt the blood from right to left and get some of that oxygen back into the left system to feed the rest of the body. So you have an O2 stat of like 85, so it's manageable, but you do have mixed blood, so you do have some cyanosis in this case. Truncus arteriosus. So in this case we've got the pulmonary artery and the aorta, they're not separated and they form one single outflow tract. And so if you have that, you have majorly mixed blood, because it's like blood going to the lungs needs to get oxygenated, blood leaving the aorta is oxygenated. So left and right side, mixed blood, increased blood pressure in the lungs because it's like so much more volume is kind of going into it. Hypoplastic left heart syndrome. So hypo meaning less, and then the plastic left heart meaning like it's not developing properly. So so it's smaller in general, and because it's so much smaller, it can't pump to the rest of the body. So what you see is you have to keep the ductus arteriosus open, and you shunt blood from the left atria to the right atria to get oxygenated blood into the right side, and then the right ventricle hyperplasias to get more blood into the aortic tract. So the hyperplasia is in the right side, hypoplasia is in the left side, and then you want to get blood out to the whole system from the right side. So left side has to give oxygen to the right side has to feed the body. Left ventricle is kind of out of the picture because it wasn't developed properly. So this classification, I would put this on my cheat sheet or make a chart of it somehow. Depends how much room you have or how much space. Yeah, because it's easy to mess up like what is mixed blood flow versus just obstruction to blood flow, and then it's good to know acyanotic versus cyanotic, especially if you're looking at clinical cases and you're trying to figure out which one of these things they are. And so I think if you understand this PowerPoint, then a lot of like the blood stuff starts to make more sense, and you start to like think more critically about like if one part of the heart fails, then what happens to the lungs, etc. And then this picture I also kept on my cheat sheet, just I guess as a reminder. It's basically the Wigger's diagram, but just in different words, I guess. You could probably have a Wigger's diagram and just label that as well, but remember that on your on the exam he'll probably give you at least 2 questions of Wigger's diagram, and he'll probably label like 1 through 7 around the diagram and say, which one corresponds to whatever, and then you'll have to identify, different things. Sometimes like what does S1 correspond to, what does S2 correspond to. And then with atrial septal defect and ventricular septal defect, because it's a high cardiac output, you might start to hear blood, like the blood going through. Patent ductus arteriosus, you hear the machine noise, the continuous murmur. But yeah, let's see. So we've got still like 10 minutes.